Compilation of ICU notes. Source: ADOT articles majorly by Dr. Sadia Sultan. Index: delirium in ICU, nutrition in ICU, ventilator associated pneumonia, physiological effects of transfer of critically ill patient, ICU, acquired weakness, sedation in ICU, weaning from mechanical ventilation, tracheostomy, renal replacement therapy, pancreatitis, ICU design and ICU, levels of care, trauma, DCR, massive transfusion protocol, DCS, ARDS. Sepsis, MUSCO, rapid response team, chain of survival, CPR, quality indicators, changes in ACLS 2020, delirium in ICU, ATOTW definition: an acute disturbance in consciousness, attention, cognition, and perception. Onset, hours to days, fluctuating course. Subtypes: hypoactive, withdrawn, easily missed, hyperactive, agitated, hallucinating, mixed, fluctuates between above, subsyndromal, some features, doesn't meet full criteria. Risk factors, patient factors, age, 70, dementia, stroke, epilepsy, depression, renal or liver failure, HIV, vision, hearing loss, social, SAM, smoking, alcohol abuse, malnutrition, environmental, IQ-related, sleep deprivation, physical restraints, catheters, urinary, rectal, central, acute illness and physiology, sepsis, hypoxia, metabolic derangements, Na+, glucose, thyroid, high Apache 2 score, pain, fever, anxiety, medications, benzodiazepines, opiates, anticholinergics, propofol, diagnosis tools, CAM. ICU versus ICD-SC1. CAM-ICU, Confusion Assessment Method, ICU gold standard and ICU direct bedside tool, requires interaction, can be done during mechanical ventilation, frequency, once every 24 hours, features assessed. 1. Acute onset fluctuation. 2. Inattention. 3. Disorganized thinking. 4. Altered consciousness. Positive CAM-ICU equals 1 plus 2 plus specificity. 99%, sensitivity. 97% good for detecting hyperactive mixed delirium. 2. ICD-SC, intensive care delirium screening checklist based on routine nursing observations, no direct patient interaction, frequency, every 8 hours, 8-item checklist, sleep, attention, hallucinations, agitation, etc. Score 4 equals delirium, 1-3 equals sub. Syndromal sensitivity, 99%, but lower specificity. 64% better at picking up hypoactive forms, useful for trending over time. Incidence varies widely. 16% to 83% hypoactive and mixed types more common than hyperactive CAM-ICU, up to 83.3% ICD-SC, 32%, often underdiagnosed without formal tools. Pathophysiology, multifactorial, dopamine. Acetylcholine equals neuronal excitability, altered serotonin, melatonin, via tryptophan and phenylalanine, inflammatory cytokines, cerebral blood flow, e.g., diffuse brain dysfunction. ABCDE bundle, prevention strategy, awakening and spontaneous breathing trials, daily sedation breaks, better sedative choices, avoid benzos, consider dexmedetomidine, choice of analgesia, remifentanil preferred, delirium monitoring, CAM. ICU or ICD-SC daily, early mobility and exercise, sleep hygiene, reduce light, noise, night interruptions management, non-pharmacological, identify and treat causes, sepsis, hypoxia. Electrolyte issues, avoid unnecessary catheters, restraints, correct vision, hearing issues, ensure orientation, calm environment, mobilize and promote natural sleep, pharmacological. 1. Haloperidol mainstay, D2 antagonist, IV 2.5 to 5 mg Q6H, reduce in elderly, side effects, QT prolongation, EPS, NMS2. Atypical antipsychotics, quetiapine, olanzapine, oral only, fewer motor side effects, may help hypoactive types used when haloperidol fails or isn't tolerated. 3. Benzodiazepines only for alcohol withdrawal, delirium, otherwise, increase delirium risk. Prognosis, mortality, up to 34% versus 15% without delirium. ICU hospital stay, 10 days longer. Costs and resource use, risk of self-extubation. Line removal, long-term cognitive impairment. 70% impaired at 1 year, duration dependent. 5 days of delirium, worse cognitive decline, nutrition ICU, malnutrition, any variation in degree of nutrition, over/under, with or without inflammation that has led to variation in body composition, undernutrition. Total energy or protein intake common in hospitalized patients strongly linked to hospital stay complications, mortality. Who's at risk of malnutrition? Any patient with ICU stay of more than 48 hours. When to do nutritional assessment of the patient in ICU? Within 24 to 48 hours of admission. How to identify high-risk patients? Based on scores, NRS and Nutrix score of 5/6, high risk of malnutrition, comorbids, Apache, SOFA, age, interleukins, NRS score of 3. Depends on WT loss, severity of surgery, assessment of nutritional status, albumin plus HB, limitations, anthropometric measurements, biochemical tests, BMI 18.5 kilograms per meter to the power of 2 equals BMI does not tell acute changes. Underweight BMI independent predictor of mortality in seriously ill patients. Most useful targeted HX and examinations. Subjective global assessment 1. Weight change acute over 2 weeks, chronic over 6 months. 2. Changes in food intake. 3. GI symptoms, NV, diarrhea, anorexia. 4. Function impairment combined with physical exam. Looking for evidence of following. 1. Loss of subcutaneous fat, chest and triceps. 2. Muscle wasting, temporal deltoid gluteal regions. 3. Edema. 4. Ascites. Nutritional requirements. Assessment of nutritional status should be used to identify patients at risk of refeeding syndrome. Nutritional requirements. Harris-Benedict equation. BMR in kcal day. BMR men equals 13.75 x WT kg plus 5 x HTCM 6.78 x age years plus 66. BMR women equals 9.56 x WT kg plus 1.85 x HTCM 4.68 x age years plus 655. Usually 25 kcal day. BMR for a febrile fever, sepsis by 10% degrees Celsius. Resting energy expenditure for each x 31 degrees Celsius 37 degrees Celsius. Macronutrients and micronutrients. Macronutrients. Protein equals 5.3 kcal g of protein. 1 to 1.5 gkg day, max 2 gkg day. Severe sepsis, burns, trauma. Lipid 9.3 kcal gram. Lipids should be 40% of total calories. Carbs 3.75 kcal g. Remaining calories should be from carbs. Micronutrients, vitamins, cofactors for enzymes, trace elements. Roots, oral, enteral, parenteral feeding. Roots 1. Oral route, encouraged for awake patients with intact swallowing ability, plus they may need supplementation orally. Enterally if oral intake not enough. This route is less invasive and maintains gut integrity. 2. Enteral, a nasogastric, most common method in ICU. Risks: malposition, discomfort, sinusitis, nasal tissue necrosis, difficulty swallowing or coughing, can reduce sinusitis. Orogastric oral tubes, suitable for intubated, not awake patients. See enterostomy, gastrostomy, jejunostomy. Well tolerated, better for those who need nutritional support. 4 weeks. Risks: during insertion, displacement, infection, peritonitis. D. Post-pyloric feeding and guidelines. Post-pyloric is a subtype of enteral nutrition. Post-pyloric feeding, nasojejunal nasojejunostomy. Tubes should be 120 centimeters long. These avoid problem of gastroparesis. Recommended for patients at high risk of aspiration. Major intra-abdominal SX intolerance to gastric feeding. IMP for enteral nutrition. Guidelines. 1. Confirm tube position. 2. Secure tube well. 3. Prop up patient 30 to 45 degrees. 4. Early feed within 24 to 48 hours. 5. Aspirate regularly, 200-250 milliliters limit. 6. Avoid bolus feeds, 70 ml TDS. 7. Use prokinetics, erythromycin, maxilin, disease-specific and when to delay. Disease-specific formulae. 1. Liver disease, low Na and AA to reduce encephalopathy. 2. Renal disease, low phos plus K, 2 kcal ml, 3. Respectively. Disease, high fat, CO2 production. Note: When enteral feed should be delayed, delay in uncontrolled shock and severe HD instability. Low dose EN as soon as shock controlled and fluids. Vasopressors, overt bowel ischemia, abdominal comp syndrome, if gastric aspirate, 500 milliliters 6 hours, bowel obstruction. Summary, enteral nutrition classification. Simplified definition, feeding beyond oropharynx into GI tract with or without surgical access, enterostomy, A. Prepyloric, NG tube. Nasogastric, OG tube, orogastric, B. Postpyloric, New Jersey tube, nasojejunal, ND tube, nasoduodenal, C. Enterostomy, PEG, percutaneous endoscopic gastrostomy, endoscopic jejunostomy, surgical. Complications of nutritional support. 1. Refeeding syndrome. 2. Overfeeding. 3. Hyperglycemia. 1. Refeeding syndrome definition, a potentially fatal metabolic complication occurring in malnourished patients when nutrition is reintroduced too rapidly, especially with carbohydrates. It results in acute electrolyte and fluid shifts due to a surge in insulin. Pathophysiology, starvation phase, low insulin, high glucagon state. Body uses fatty acids and ketones for energy. Intracellular stores of phosphate, K. Mg to the power of 2 become depleted. Refeeding phase, sudden carbohydrate intake. Insulin release. Insulin drives glucose plus electrolytes, phosphate, potassium, magnesium into cells. Serum levels fall rapidly. Na and fluid retention. Risk of overload. Thiamine deficiency worsens ATP production. Electrolyte abnormalities. Phosphate, hallmark feature. Potassium, magnesium, calcium. Thiamine. Risk factors, BMI 16 kilograms per meter to the power of 2. Unintentional weight loss, 15% over 3-6 months. Little no intake, 10 days. NPO. Chronic alcoholism. Anorexia nervosa. Prolonged fasting, critical illness, cancer. Cachexia. Insulin-dependent influx of electrolytes during refeeding. Clinical features, within 24 to 48 hours. Muscle weakness. Respiratory failure. Cardiac failure, arrhythmias. Seizures. Coma, sudden death. Biochemical signs, hypophosphatemia, hypokalemia, hypomagnesemia, hypocalcemia. Elevated LFTs. Low albumin. Thiamine deficiency. Wernicke's encephalopathy. Prevention and management. Prevention, identify at-risk patients before starting feed. Start slow feeding. 10 kcal/kg day. Give thiamine 100-300 mg day before and during refeeding. Monitor and correct electrolytes daily. Delay full caloric intake until electrolytes are stable. Repletion, replace phosphate, potassium, magnesium. Aggressively start parenteral thiamine before carbohydrates. Remember, with refeeding, metabolism switches from fat to glucose. Insulin surge. Intracellular shifts. Electrolyte crash. 2. Overfeeding, deliberately done to reverse catabolism. Poor outcome. It causes uremia, hyperglycemia, hyperlipidemia, hypercapnia. Fatty liver. Fluid overload. Propofol 10%, intralipid, should be included in calculations for nutritional support if overfed, to be avoided. 3. Hyperglycemia, can be related to overfeeding. Critically ill are actually insulin resistant. NICE guidelines suggest glycemic control between 6-10 mol/L. Commonest complication of EN equals aspiration plus diarrhea is not an indication to stop feeding enterally. Indications for EN and PN. EN should be started in patients even with ECMO prone positioning, stroke, acute pancreatitis, GISX, ABD. Aortic SX regardless of bowel sounds. Parenteral nutrition. PN. Absolute indication for PN. Gastrointestinal failure can be used to supplement enteral feeding, e.g., in short gut syndrome, or used as sole source of nutrition. TPN when EN is contraindicated. Ischemia, obstruction, perforation, prolonged ileus, GI fistula, non-functioning gut. TPN composition. TPN should be considered when EN expected not to be tolerated for 5 to 7 days when enteral nutrition is unable to meet 70% demands of caloric requirements of the patient given as sterile emulsion of water, protein, lipids, carbs, electrolytes, vitamins, trace elements. Protein, as amino acids AA, essential plus non-essential. Glutamine tends not to be included. Problems equals stability, solubility. Lipids, Given as intralipid emulsion from soya plus kilomicrons source of essential Fa, linoleic 6% of total energy as lipids enough. Also its expensive problems associated with total parenteral nutrition TPN. Route of administration, a concerned central line CVC preferred peripheral line not ideal for TPN. Why peripheral line is not preferred? 1. TPN is hypertonic, can cause thrombophlebitis, therefore not used via peripheral line. 2. If peripheral line must be used, only isotonic solutions can be given, requires large volumes of fluid, increased risk of fluid overload, hence, TPN should always be given via a central line. Complications of TPN. 1. Catheter-related problems, infection insertion issues, pneumothorax, hematoma, thrombosis, catheter displacement. 2. Metabolic complications, hyperglycemia, hypoglycemia, metabolic acidosis, electrolyte imbalances, increased CO2 production, hypertriglyceridemia, deficiency of essential nutrients. 3. Intestinal complications, villus atrophy, due to disuse of gut mucosa. 4. Parenteral nutrition also disposes to fatty liver cholestasis, acalculous cholecystitis, electrolyte imbalances, micronutrient deficiencies. Important note, hypophosphatemia is a common and serious complication of TPN. Monitor closely. Requirements on daily basis. Water, 30 milliliters kg Na. 1-2 mol kg Cl to the power of negative 1-2 mol kg K. 0.7 to 1 mol kg Ka plus mg. 0.1 mol kg each PO4 negative 2. 0.4 mol kg. Ventilator-associated pneumonia VAP definition: hospital. Acquired pneumonia occurring 48 hours after intubation and mechanical ventilation. Early onset VAP, 96 hours, usually community acquired, antibiotic sensitive organisms. Late onset VAP, 96 hours, often caused by multi-drug resistant, MDR organisms like Pseudomonas or MRSA. Incidence affects 13.6 per 1,000 ventilator days, varies with setting. Causes 50% of antibiotic use in ICU. Develops typically 5 to 7 days after intubation. Mortality ranges from 24 to 76%. Pathophysiology at tracheostomy: impaired mucociliary clearance plus pooled secretions, micro-macro aspiration. Secretions carry pathogens into lungs, especially in sedated patients. Biofilm forms inside et protects bacteria. ICU patients equals immunocompromised, higher risk of pneumonia. Pulmonary edema and inflammation further increase risk. Common pathogens: early onset, Haemophilus influenzae, Streptococcus pneumoniae; late onset, Pseudomonas aeruginosa, Acinetobacter, MRSA. Risk factors: general risk factors. Age, 55 years, chronic lung disease, chest or upper abdominal surgery, reintubation or prolonged intubation, aspiration, microaspiration, e.g., supine position, trauma, polytrauma, ARDS. Frequent ventilator circuit changes, prolonged paralysis, malnutrition, renal failure, anemia. MDR pathogen risk factors. IV antibiotics within past 90 days, septic shock at VAP onset, ARDS preceding VAP, 5 days hospital stay prior to VAP, acute renal replacement therapy prior to VAP, VAP prevention. Converted bundle, text version, to reduce aspiration. Nurse patients in a semi-recumbent position, 30 to 45 degrees head up, maintain at cuff pressure, 20 cm H2O, use subglottic suction at if ventilation expected, 72 HRS, avoid unnecessary at changes to optimize microbial ecology. Stop stress ulcer prophylaxis in low-risk patients, maintain oral hygiene, basic care, practice infection control, hand hygiene, avoid unnecessary circuit changes to reduce mechanical ventilation duration. Perform daily sedation breaks, assess daily for readiness to extubate to manage ICU microbial ecology, monitor local VAP rates, involve microbiology team for local resistance patterns and appropriate ABX guidance, diagnosis, clinical clues. Fever, purulent secretions, leukocytosis, leukopenia, hypoxia, minute ventilation, tidal volume CXR, new infiltrate CRP, procalcitonin, supportive, not diagnostic, sampling. Send respiratory samples before starting antibiotics. Tracheal aspirate mini BAL, bronchoscopic BAL or protected specimen brush, more accurate but not proven to reduce mortality. Scoring systems. 1. Clinical pulmonary infection score, CPIS, parameter score details temperature, degrees Celsius, 0. 36.5 to 38.4. 1. 38.5 to 38.9. 2. 36 or 39 WBC count, cells mm to the power of 3, 0. 4,000 to 11,000. 1. 4,000 or 11,000. 2. Plus band cells 500 tracheal secretions 0, none. 1. Non-purulent. 2. Purulent chest X-ray infiltrates 0, none. 1. Diffuse patchy. 2. Localized culture of respiratory sample 0, no mild growth. 1. Moderate florid growth. 2. Growth matching gram stain PaO2/FiO2 ratio 0, 240 or ARDS present. 2. 240 without ARDS interpretation. CPIS 6 suggests likely VAP sensitivity 65%, specificity 64%. Inter-user variability present. Score should decline on day 3, if yes equals good Rx, if score rising equals change ABX2. Helix criteria, Europe-wide surveillance standard, diagnosis requires all 3, radiological, 2 chest X-rays or 1 if no underlying lung cardiac disease, with features of pneumonia systemic, at least 1 of, fever, 38 degrees Celsius. Leukocytosis, leukopenia pulmonary, at least 1 of, new worsening purulent sputum, worsening gas exchange, new cough dyspnea, Ral's bronchial sounds. Treatment start empirical broad spectrum antibiotics immediately. Cover Pseudomonas, MRSA, gram-negative bacilli. Non-MDR, Rx to continue for 10 days. MDR, Rx to continue for 15 days. Adjust based on local antibiogram previous cultures. Risk of MDR pathogens de-escalate once culture results available. Total duration 7 days, if good clinical improvement. Summary: VAP equals deadly, common ICU infection. Early detection and prevention are critical. Diagnosis relies on scoring systems plus clinical suspicion, not a single test. Bundles reduce incidence. Subglottic suction tubes, elevation, daily sedation breaks are key. Empiric ABX de-escalate stop at 7 days if stable. Antibiotic stewardship is essential to reduce resistance. Curb 65 score for pneumonia. Each of the following 5 criteria scores 1 point. 1. C. Confusion, new disorientation to person, place, or time. 2. Urea, 7 mol/L, or BUN, 19 mg/dl. 3. R. Respiratory rate 30 breaths per minute. 4. B. Blood pressure, systolic, 90 mmHg or diastolic 60 mmHg. 5. 65 age 65 years, interpretation. 0-1 points, low risk outpatient treatment 2 points, moderate risk consider hospital admission 3 points, high risk admit, consider ICU if 4. Physiological effects of transfer for critically ill patients, ATOTW. 1. Introduction. Critically ill patients often need to be transferred, e.g., for specialist care or repatriation. In the UK, over 11,000 inter-hospital critical care transfers occur annually. These transfers carry significant risks. In one audit, 34% of transfers had adverse events, 70% of which were avoidable. Risks mainly arise from patient instability due to illness or drugs, equipment failure, poor preparation and communication, inertial forces and environmental changes when to intubate before transferring a patient. AAGBI guidelines. Categories to consider. 1. CNS indications: Glasgow Coma Scale GCS 8 or less, drop in GCS by 2 or more points, seizures, loss of power and motor function of lower limbs. 2. Respiratory indications: loss of laryngeal reflexes, absent cough and gag. PaO2, 8 kPa or PaCO2, 4 kPa or 6 kPa. 3. Airway indications: unstable facial fractures, bleeding into the airway. 2. Physiological effects of land transfer. A. Inertial forces. Newton's laws: acceleration equals force towards patient's head, inertia shifts organs and blood, caudally venous return and preload. Deceleration equals force towards feet, inertia shifts blood cranially ICP. These effects are strongest in the cephalocaudal axis, head to toe. B. Cardiovascular effects: acceleration, blood pools in lower extremities, venous return, cardiac output, hypotension exacerbated by hypovolemia or positive pressure ventilation, deceleration. Blood shifts to thorax, head can overload, a failing heart failure, arrhythmias, pulmonary edema. C. Neurological effects: acceleration-induced hypotension, cerebral perfusion pressure, CPP. Deceleration increases intracranial pressure, ICP. CPP equals MAP ICP. Any rise in ICP or fall in MAP reduces brain perfusion. D. Gastrointestinal effects: cranial shift of stomach contents during deceleration increases aspiration risk. Displaced viscera raises transdiaphragmatic pressure, alters tidal volumes or airway pressures. E. Musculoskeletal effects: axial loading during deceleration can displace unstable spinal fractures. F. Static hazards during land transfer: noise, hinders staff communication, increases patient distress. Temperature: ambulances may not maintain stable temperatures, risk of hypothermia. Duration-related risks: pressure injuries from prolonged immobility, avoid prolonged use of spinal boards, damage seen in 20 minutes in healthy volunteers, use vacuum mattress instead. Equipment security: all equipment must be fastened. Staff must wear seat belts. 3. Physiological effects of air transfer: A. Hypoxia at altitude, atmospheric pressure decreases with altitude. FiO2 remains constant at 21%, but partial pressure of O2 (PO2) falls. At sea level, PO2 13.2 kPa, 99 mmHg; at 10,000 feet, PO2 6.7 kPa, 50 mmHg. This causes hypoxia unless FiO2 is increased. Aircraft flies at a lower altitude, cabin is pressurized. High-risk patients, those with COPD, pulmonary contusions, or fibrosis. Increased AA gradient. B. Gas expansion: Boyle's law, gas volume increases as pressure falls. Clinical implications: pneumothorax, must be drained before flight to avoid tension. Recent abdominal surgery or bowel obstruction, risk of gas expansion and anastomotic rupture. Intracranial air, worsens ICP, avoid air transfer if possible. ET tube cuffs, stoma bags, Sengstocken tubes, cuff pressure rises, risk of mucosal injury. Use saline to fill cuffs, or monitor pressure closely. See temperature and humidity: temperature falls 2 degrees Celsius per 1,000 feet ascent, hypothermia risk. Dry air leads to dehydration, skin lung moisture loss, thickens secretions, risk of airway obstruction. Prevention: humidify oxygen, use HME filters, lubricate eyes. Provide oral care, monitor fluid balance during long transfers. D. Vibration and noise: vibration can fatigue staff and interfere with NIBP monitoring. Use arterial line for accurate blood pressure. Helicopters are noisy. Communication via headsets. Ear protection for patient. Staff should monitor for fatigue and remain hydrated. E. Space limitations: in flight intubation is nearly impossible, especially in helicopters. Intubate any patient at risk of deterioration before transfer. F. Altitude practices: helicopters usually fly at low altitude 1,000 feet but can't pressurize cabin. Fixed-wing aircraft fly at higher altitudes but can pressurize cabin to 7,000 feet or even sea level. 4. Patient preparation before transfer: general measures for land and air. Fully stabilize the patient, airway, breathing, circulation, sedation, and equipment. Head up tilt to 15 degrees reduces ICP rise. Elevate legs during acceleration to improve preload. Intubate patients at risk of vomiting or airway compromise. If not intubated, give antiemetics. Place NG tube to decompress stomach. Use warm blankets and fluid warmers to avoid hypothermia. Monitor temperature, vitals, and pressure areas closely. Secure all lines and devices. Avoid resting anything on the patient. Use vacuum mattress over spinal board for prolonged transfers. Air-specific measures: drain pneumothorax before ascent. For known intracranial air or recent bowel surgery, avoid air travel or use low-altitude pressurized cabin. Consider filling ET cuff with saline. Insert arterial line if accurate BP needed. Communicate with pilot about flying altitude. Use HME filters, artificial tears, oral care for long flights. 5. Mode of transport comparative summary, land ambulance, advantages, familiar, cheaper, fast to mobilize, better in bad weather, easier for monitoring, limitations, slower over long distances, traffic issues, not suitable for remote terrain. Helicopter, advantages, fast, good for remote locations, direct hospital access if helipad exists, limitations, unpressurized, costly, weather dependent, limited space, unfamiliar to some staff. Fixed wing aircraft, advantages, pressurized cabin, better for long distances, more comfortable environment, limitations, high cost, coordination challenges, need land transport to from airfield. 6. Final summary, critically ill patients have reduced ability to compensate physiologically. Transfers expose them to hypoxia, hypotension, raised ICP, aspiration, and pressure injuries. Risk is highest during acceleration, deceleration, altitude changes, temperature extremes, and equipment failure. Prevention requires proper planning and stabilization, understanding of physical forces, e.g., Newton's laws, Boyle's law, team awareness of environmental, logistical, and equipment-related hazards. These considerations apply equally to patient, staff, and equipment during transfer. ICU acquired weakness, ICU definition. Clinically detectable weakness in ICU patients with no other identifiable cause except critical illness itself. Types: CIP critical illness, polyneuropathy, CIM critical illness, myopathy, CINM critical illness, neuromyopathy. Overlap of CIP and CIM. Risk factors, probable factors, sepsis, multi-organ failure, prolonged mechanical ventilation, hyperglycemia, extended ICU stay. Possible factors, age, older patients, female sex, severe illness, e.g., MODS, ARDS. Parenteral nutrition, renal replacement therapy, vasopressors, corticosteroids, neuromuscular blocking agents. Pathophysiology, CIP. Hypothetical mechanisms. Microcirculatory impairment due to vasodilation and myocardial depression, shunting of blood tissue, hypoxia, mitochondrial dysfunction and impaired ATP production, axonal injury, CIM. Sodium channel inactivation, decreased muscle membrane excitability, impaired calcium handling in sarcoplasmic reticulum, reduced contractility, decreased contractile protein function, muscle denervation and atrophy, proteolysis. Synthesis, apoptosis, bioenergetics, failure due to mitochondrial dysfunction. Clinical features, symmetric, flaccid weakness, proximal, distal, facial muscles often spared. Earliest sign may be facial movement without limb movement, sensation usually intact, reflexes reduced or absent, no cranial nerve involvement, ventilator weaning difficulty may be the first clue. Differential diagnosis important to rule out. Guillain-Barré syndrome, GBS, ascending paralysis, areflexia, albuminocytologic dissociation on lumbar puncture, myasthenia gravis, fluctuating weakness, ptosis, diplopia, preserved sensation, botulism, descending paralysis. Cranial nerve signs, dilated pupils, electrolyte imbalance, sudden, diffuse weakness, check for hypokalemia, hypophosphatemia, spinal cord injury, stroke, sensory level or focal deficits, localizing signs, confirmed on imaging, poliomyelitis, rare. Fever plus asymmetric flaccid paralysis, drug-induced weakness, prolonged steroids or neuromuscular blockers causing myopathy or persistent blockade. Diagnosis, electromyography EMG, helps differentiate CIP conduction versus CIM. Muscle changes, nerve conduction studies, normal in CIM, abnormal in CIP. Creatine kinase CK, typically elevated in CIM. Lumbar puncture, done to rule out GBS. Muscle biopsy, definitive if diagnosis remains unclear. Management. Address underlying illness, sepsis, MODS, tight glycemic control, target 110-150 mg/dl, avoid prolonged steroids and neuromuscular blockers, early physiotherapy and mobilization to prevent deconditioning, nutritional optimization. Preferably enteral, minimize sedation and aim for early weaning from mechanical ventilation, multidisciplinary rehabilitation post-ICU if weakness persists. Prognosis. CIM tends to recover earlier than CIP. CIP recovery is slow. Axonal regrowth occurs at 1 day. Persistent weakness may affect functional recovery and long-term quality of life. Mortality relates more to the severity of the underlying illness than the weakness itself. Sedation and ICU. ATOTW, sedation in ICU. Summary introduction. Sedation is vital in ICU care for reducing anxiety, discomfort, and agitation. Enabling procedures like intubation, suctioning, and ventilation. Improving sleep and rest. Reducing the metabolic response to surgery. Trauma. Consequences of oversedation, hypotension, delayed recovery, weaning, gut ileus, DVT, nausea, immunosuppression. Consequences of undersedation, hypertension, tachycardia, increased O2 demand, myocardial ischemia, tube intolerance, infection risk. Non-pharmacologic strategies, verbal reassurance and communication control. Lighting, temperature, humidity, and noise explain all procedures. Manage hunger, thirst, constipation, bladder. Allow interaction, visitors, radio. Maintain day-night cycle, assessing sedation goals, individualized dosing, pharmacodynamic variation. Regular, reproducible assessment. Ramsey sedation scale. 1. Anxious and agitated. 2. Cooperative, oriented, and tranquil. 3. Responds only to verbal commands. 4. Asleep, brisk response to loud auditory stimulus or glabellar tap. 5. Asleep, sluggish response to loud stimulus. 6. Asleep, no response. Target levels. 2-5 in ICU. Richmond agitation sedation scale, RASS, +4, combative, dangerous to staff. +3, very agitated, pulling tubes. +2, agitated, frequent non-purposeful movement. +1, restless but non-aggressive. 0, alert and calm. -1, drowsy. Sustained awakening to voice, TENS, -2, light sedation, brief eye contact to voice, TENS, -3, moderate sedation, eye opening to voice but no eye contact. -4, deep sedation, movement to physical stimulation only. -5, unrousable, no response at all. Ideal target. 0 to -1. Practice tip: use daily sedation holds plus spontaneous breathing trials to shorten ICU stay and ventilation. Sedative agents: 1. Benzodiazepines, midazolam, lorazepam, diazepam, anxiolytic, hypnotic, amnesic, muscle relaxant. Act on GABA receptors. Minimal CV. Resp. Depression. Midazolam, water-soluble at acidic pH, fat-soluble at physiological pH. Rapid onset, short half-life, 2H, but can accumulate. Metabolite: 1-hydroxymidazolam, accumulates in ICU patients. Lorazepam, undergoes glucuronidation, inactive metabolites reversed by flumazenol. Short-acting, diazepam, long half-life due to active metabolites. Avoid an elderly or hepatic dysfunction. 2. Propofol, GABA agonist, different site than benzodiazepines, rapid onset offset, metabolized hepatically and extrahepatically. Risk: hypotension, bradycardia, propofol infusion syndrome, PIES, not licensed for children in ICU. Max dose: 4 mg kgh3. Ketamine, NMDA receptor antagonist analgesic plus sedative, increases BP, HR, ICP used in asthma, bronchodilator, risk of hallucinations. Use with benzodiazepines. 4. Etomidate, adrenal suppression after even 1 dose, no longer used in ICU. 5. Barbiturates, thiopentone, used in refractory seizures or high ICP-CV depression, long recovery. Dose titrated using EEG burst suppression. 6. Haloperidol butyraphanone, good for delirium. Minimal respiratory depression. Side effects: QT prolongation, extrapyramidal symptoms, NMS7. Clonidine, Greek letter alpha-2 agonist, reduces sympathetic tone. Useful in alcohol withdrawal, tetanus. Side effects: bradycardia, dry mouth, hypotension. Dexmedetomidine is a more selective, but costly, alternative. 8. Chloral hydrate, chlormethiazole, used in pediatrics and delirium tremens. Minimal respiratory depression. Risk of metabolite accumulation. 9. Volatile agents, isoflurane, desflurane, sedative effect at low concentrations. Rapid wake up, minimal CV effects. Concerns: pollution, vaporizer integration. Analgesics used in ICU. 1. Morphine, variable dosing, risk of accumulation especially in renal failure metabolized to M6G sedative and M3G histamine release risk 2. Fentanyl, synthetic, potent, fast onset minimal histamine, safe in renal failure 3. Alfentanil, faster onset than fentanyl, shorter acting minimal accumulation, expensive 4. Remifentanil, ultra-short acting, esterase metabolism no accumulation and organ failure predictable recovery, enables early weaning expensive but may reduce ICU stay also use, NSAIDs, paracetamol, epidural infusions as adjuncts. Neuromuscular blocking agents indications, intubation severe ARDS, reduce O2 consumption, raised ICP tetanus during transport facilitate prone inverse ratio ventilation caution. No sedative or analgesic properties, ensure deep sedation use nerve stimulator train of 4, for monitoring drugs, succinylcholine, emergency intubation, avoid and burns, renal failure pancuronium, long-acting, causes tachycardia. Accumulates in renal failure vecuronium, less CV effects, suitable for infusion atracurium, ideal metabolized by Hoffman elimination plus ester hydrolysis risks. 1. Inadequate sedation awareness 2. Drug accumulation 3. Critical illness neuropathy 4. Risk of oversedation 5. Potentiated by hypokalemia, hypophosphatemia, aminoglycosides. Practical recommendations non-ventilated patients use opioids for pain control combined with simple analgesics PCA and regional blocks when appropriate short. Term ventilation 72H, preferred, remifentanil propofol combo alternative, midazolam plus morphine long-term ventilation avoid short. Acting agents daily sedation interruption reduces ventilation time midazolam plus morphine or propofol consider patient-controlled sedation PCS in select cases, requires special setup drug doses propofol, 0.5 to 4 mg kgh bolus. 5-50 mg note, avoid in children, hypotension and hypovolemia midazolam, 0.5 to 10 mg bolus. 2-4 mg in children. 5 mg kg in 50 ml equals 1 ml H 100 mcg kgh morphine. 1-5 mg bolus. 2-5 mg in children. 1 mg kg in 50 ml equals 1 ml H 20 mcg kgh fentanyl. 1-3 mcg kgh bolus. 50-100 mcg in children. 50 mcg ml equals 0.3 to 0.5 milliliters H, 5-10 mcg kgh, alfentanil. 1-5 mg H bolus. 0.5 to 1 mg short-acting, minimal accumulation haloperidol. 5-10 mg bolus minimal respiratory depression ketamine, bolus 1-2 mg kg infusion. 10-45 mcg kg mingutin esmethiopentone. 50-250 mgh used in epilepsy and raised ICP remifentanil, start at 0.1 to 0.15 mcg kg min titrate up to 0.6 mcg kg min no accumulation, expensive, may cause bradycardia. Weaning from mechanical ventilation definition weaning is the gradual process of reducing and ultimately removing ventilatory support, aiming for 1. Liberation from the mechanical ventilator 2. Removal of artificial airway, tracheostomy, modifiable factors that may prevent weaning use the mnemonic WEANS not for common reversible causes, wheeze, cough asthma, treat bronchospasm heart disease fluid overload, use diuretics. E.g., furosemide electrolyte metabolic derangements, correct abnormalities anxiety delirium, address with anxiolytics or antipsychotics if needed neuromuscular disease or weakness sepsis, optimize treatment first nutrition. Ensure adequate support opioids and sedatives, should be minimized or weaned off thyroid disease, rule out thyroid crisis, if not addressed. These factors will prevent successful weaning and extubation. Consequences of delayed weaning 1. Increased incidence of ventilator-associated pneumonia VAP2. Increased risk of venous thromboembolism 3. Prolonged ICU stay and higher mortality 4. Higher risk of ICU acquired weakness, critical illness myopathy, best weaning strategy previously, SIMV was used but now less favored due to risk of breath stacking increased chances of barotrauma current preferred mode. Pressure support ventilation PSV is best can be followed by a TPS trial before extubation spontaneous breathing trial SBTA trial of breathing without ventilator support to assess readiness for extubation. Patient is shifted from controlled mode e.g., VCV, to a support mode e.g., PSV, and allowed to breathe spontaneously for 30 minutes. If the patient maintains stability SBT successful. If unstable SBT failed, successful weaning defined as sustained removal from mechanical ventilator for at least 48 hours after extubation, without the need for reintubation or non-invasive ventilation NIV. Some sources accept success if patient remains off invasive ventilation for 7 days post-extubation, even if on nocturnal CPAP BiPAP. Weaning classification 1. Simple weaning, successful extubation on first SBT 2. Difficult weaning, requires 2-3 SBT attempts or takes up to 7 days 3. Prolonged weaning, more than 3 failed SBTs or 7 days needed for weaning. Criteria for extubation prior to or after SBT divided into 5 categories. 1. Clinical criteria: alert with intact cough gag reflex, resolution of acute disease, minimal airway secretions, hemodynamically stable, MAP 65 mmHg. 2. RSBI, Rapid Shallow Breathing Index, RSBI equals RRVT in liters, RSBI, 105 suggests readiness to wean, RSBI, 105 indicates poor weaning tolerance. 3. Oxygenation criteria, PaO2, 60 mmHg on FiO2 0.4 ppb 5-8 cm H2O SPO2, 90% PaO2/FiO2 ratio, 200 Qs QT, shunt fraction 20%. 4. Pulmonary reserve, p. 8 cm H2O hemoglobin, 8 gdl max inspiratory pressure MIP-30 cm H2O 5. Ventilatory strategy criteria, PaCO2, 50 mmHg RR35/min, spontaneous, normal ABGs. When to abort SBT trial failure criteria, abort the SBT if any of the following occur. RR, 35/min 4, 5 minutes SPO2, 90% HR, 140 BPM systolic BP, 180 or 90 mmHg. New anxiety, panic, agitation, or arrhythmia. In such cases, stop the trial and return to controlled ventilation mode. Role of ultrasound, US. In weaning, assess air column around it. For tracheal edema, check B lines for fluid overload. Evaluate cardiac function via T or transthoracic echo. Identify diaphragmatic dysfunction. Role of non-invasive ventilation NIV. In weaning, no benefit in general population, but helpful in COPD patients, cardiogenic pulmonary edema, airway edema, and extubation to assess for post-extubation stridor risk. Perform cuff leak test. Use ultrasound to assess air column width around it. Tracheostomy. Key facts: performed typically between second and third tracheal rings if done above. Risk of subglottic stenosis if done below. Risk of innominate artery bleeding in practice, often placed at the second ring. Indications: 1. Upper airway obstruction. 2. Prolonged mechanical ventilation. Most common ICU indication e.g., tetanus, MV, 14 days. 3. Protection of airway in diseases with increased secretions e.g., ALS. Absolute contraindications for tracheostomy: uncorrectable coagulopathy, infected or distorted neck anatomy, trauma, thyroid cartilage. No access to anatomical landmarks. Patient refusal. Elective cases. Advantages: reduces sedation requirement, allows better oral hygiene, decreases work of breathing, improves patient comfort, facilitates ventilator weaning. Complications: early hemorrhage, most common and earliest pneumothorax, intermediate tracheoesophageal fistula, stomal infections, surgical emphysema, late tube displacement, tracheal stenosis, mucus plug obstruction. Care of tracheostomy: regular suctioning, humidification, CPAP to tracheostomy, if needed, tube replacement after 3 to 5 days, bedside formal change by 7 to 10 days, post-surgical tracheostomy, blocked tracheostomy, emergency algorithm. 1. Remove inner cannula. 2. Suction through the tube. 3. Deflate the cuff. 4. Remove the tracheostomy tube. Always ensure adequate airway backup is available. Trained personnel are present for tracheostomy management. Equipment ready for oral intubation or reinsertion. Renal replacement therapy, RRT, article from ATOTW, renal replacement therapy, RRT, in ICU. Definition of AKI, acute kidney injury. Abrupt kidney function decline within 48 HRS with serum creatinine 0.3 mg/dl or 50% from baseline urine output, 0.5 ml kg/hr 6 hours. Indications for RRT1. AKI with complications, fluid overload not responsive to diuretics. 6.5 mol LPH 7.1, severe metabolic acidosis, urea, 30 mol L or rising rapidly. Symptomatic uremia, encephalopathy, pericarditis, nausea. Oliguria or anuria. 2. Toxin removal, dialysable drugs like lithium, methanol, salicylates. 3. Sepsis. Experimental use, cytokine removal via high-volume hemofiltration, types of RRT in ICU. Intermittent hemodialysis. IHD. Continuous RRT, CRRT, CVVH, CVVHD, CVVHDF, SCUF hybrid e.g., SLED. Mechanisms. Dialysis equals diffusion. Good for small solutes. Filtration equals convection. Better for cytokines, large solutes. Hemodiafiltration equals both diffusion plus convection. IHD versus CRRT. IHD, rapid solute water removal, for stable patients. CRRT, slower, continuous. Better for unstable, septic, or head injury patients. Dose of renal replacement therapy. Flow rate equals dose. Standard dose 20 ml kg/hr. Intensive, not superior. 35 ml kg/hr. No mortality benefit seen with higher doses and trials. Anticoagulation and CRRT not needed if coagulopathy exists. INR 2.5, APTT 60s, PLT 60K if needed. Heparin UFH preferred, reversible with protamine LMWH. Rare use, longer half-life. Prostaglandins, alternative in bleeding risk. Citrate, regional anticoagulation. Risks include hypoca, alkalosis, vascular access. Preferred, right internal jugular, straight root subclavian. Clean but risk of stenosis, pneumothorax. Femoral, easy access, high infection risk. Filter characteristics. High flux, synthetic membranes. Preferred e.g., polysulfone. Function depends on surface area, pore size, biocompatibility. Adsorption capacity, replacement fluids. Lactate-based, cheap, but avoid in lactic acidosis. Liver failure. Bicarbonate-based, safer in acidotic or liver-impaired patients. Drug clearance considerations. Drugs poorly cleared if highly protein-bound. Given between intermittent sessions. Clearance depends on molecule size, filter type, RRT mode, timing, and dose. Complications of RRT: hypotension, filter clotting, electrolyte imbalances, infection, sepsis from catheter, blood loss, platelet consumption, hypothermia, air embolism. Outcomes: ICU mortality in AKI needing RRT 60%. 80% of survivors are dialysis independent at 1 year. Example order: CRRT for 75 kg septic AKI. Modality: CVVHDF. Access: right IJV, 12 FR double lumen anticoagulation. UFH, 40-70 units kg, 5. 000 IU bolus plus 500 IU/hr. Pre-filter replacement fluid, bicarbonate-based, potassium-free. Exchange rate 2600 ml/hr, 1300 UF plus 1300 dialysate. Fluid target, -1500 ml and 24 HRS. Monitoring, UNEQ6H, APTTQ6H, TMP alarms. Drugs removed by RRT. These are water-soluble and low-protein bound. Lithium ethylene glycol methanol salicylates metformin aminoglycosides barbiturates cephalosporins penicillins carbapenems metronidazole mnemonic for removed toxins, optional, lemsam CPCM lithium, ethylene glycol, methanol. salicylates, aminoglycosides, metformin, penicillins, drugs not removed by RRT. These are highly protein-bound or lipophilic. Digoxin tricyclic antidepressants, phenytoin glycoside beta blockers except atenolol. Warfarin, benzodiazepines, macrolide and quinolone. Antibiotics. Acute pancreatitis, defined as inflammation of the pancreas. Etiologies: mnemonic. I get smashed. G. Gallstones, 50%. E. Ethanol alcohol abuse. Common cause. T. Trauma. S. Steroids. M. Mumps. A. Autoimmune pancreatitis. S. Snake scorpion bite. Other toxins. H. Hyperlipidemia, especially triglycerides, 1000 mg/dl. E. ERCP-induced. D. Drugs, e.g., azathioprine, diuretics, valproate. Clinical presentation: sudden epigastric pain plus or minus ruck pain. 50% have band-like radiation to back associated with nausea. Vomiting can follow 3+ days post. Alcohol binge rarely presents as shock, coma, severe systemic signs. Signs on examination: epigastric tenderness, guarding, distension, Cullen's sign, periumbilical bruising, Gray-Turner's sign. Flank ecchymosis, retroperitoneal hemorrhage, pleural effusion, dyspnea, suspectards or ACS. Pathogenesis of acute pancreatitis. Protective mechanisms: normal physiology, zymogen packaging, low intra-acinar calcium, intracellular trypsin inhibitors. Pancreas normally produces proteolytic enzymes in inactive forms, zymogens. Enzymes are activated in duodenum by enterokinase trypsinogen trypsin cascade if disrupted, e.g., by gallstones, alcohol, trauma. Premature trypsin activation in acinar cells leads to autodigestion, inflammation, edema, necrosis, and systemic cytokine storm. Progresses to Kurzmaff sepsis, death if uncontrolled. Ranson's criteria for severity at admission: halal, hyperglycemia, BSR, 200 mg/dl, 11.1 mol/L, age, 55 years, leukocyte count, 16,000/mmast, 250 IUL, LDH, 350 IUL, at 48 hours, birthday party cake for her husband, base deficit, 4 mEq/2, 8 kPa, 60 mmHg, calcium serum 8 mg/dl, 2 mol/L, fluid sequestration, 6 liters, urea bun increase, 5 mg/dl. 1.8 mol/L, hematocrit fall, 10%. 3 criteria equals severe pancreatitis. CT severity index, CTSI, grade A, normal pancreas 0, grade B, focal diffuse enlargement 1, grade C, peripancreatic inflammation 2, grade D, intra-extra pancreatic fluid collection 3, grade E, gas in pancreas, retroperitoneum 4, necrosis score 0% to 33%, 433 to 50%, 50% total score 6 equals severe disease. Investigations: biochemical tests, serum amylase lipase, Rison 6-12 HRS. Stay elevated 3 to 5 days. CRP, 150 mg/dl at 48 HRS indicates severe inflammation. Radiology, CT abdomen with oral and IV contrast, most reliable for necrosis, severity grading, and complications. Ideal after 48 hours. Abdominal USG. Best for detecting gallstones. CBD dilatation should be done in every first-time attack. X-ray abdomen, exclude obstruction, perforation. Findings: sentinel loop, ground glass appearance. Ascites chest X-ray may show bilateral pleural effusions, ARDS, elevated hemidiaphragm, atelectasis. Mortality patterns: early mortality first 2 weeks, due to SIRS and multi-organ failure. MUF, late mortality due to infected necrosis. Sepsis. Overall mortality, 10%. Severe pancreatitis, up to 30%. Management, general ICU support. Admit all patients with moderate severe disease to high dependency or ICU. ABC stabilization plus strict hemodynamic monitoring. Arterial line, CVP, hourly urine output, daily weight, labs: bun, creatinine, calcium, glucose, CRP1. Fluid resuscitation, early and aggressive fluid therapy is essential. Use Ringer's lactate, preferred over NS due to better pH control, 30 ml/kg in first 24 hours. Goal-directed therapy, target, MAP, 65 mmHg, urine output, 0.5 ml/kg H. HR 120 bpm, lactate should. 2. Nutrition, enteral feeding preferred over parenteral if oral intake not tolerated. Nasojejunal, New Jersey, tube preferred over nasogastric. Begin within 24 to 72 HRS in moderate severe cases. 3. Pain management, IV opioids, morphine, fentanyl PCA or thoracic epidural for severe pain. Avoid NSAIDs and hypovolemia. Morphine may cause sphincter vasospasm. Use fentanyl if concerned. 4. Management of hypocalcemia, common due to fat saponification and hypoalbuminemia. Monitor corrected calcium. Treat symptomatic hypocalcemia with IV calcium gluconate. 5. Management of hyperglycemia, due to stress response, Greek letter beta cell dysfunction, and insulin resistance. Monitor capillary blood glucose every 4 to 6 hours. Use insulin infusion if needed. Target glucose 140-180 mg/dl. 6. Infection prevention and management. Infected necrosis develops in 30% of severe cases. Start early enteral feeding to reduce gut translocation. Avoid prophylactic antibiotics unless infection suspected. When infection is suspected, empiric antibiotics imipenem, meropenem, or piperacillin tazobactam. Blood cultures, CT-guided FNA if needed. 7. Interventions for infected collections, conservative initially if worsening or septic, CT-guided percutaneous drainage. Minimally invasive necrosectomy preferred over open surgery. Timing, delay surgery, 4 weeks if possible. Complications, local, pancreatic pseudocyst abscess, hemorrhage, pancreatic duct disruption, necrosis, infected necrosis, systemic, SIRS-Mafard's, renal failure, DIC, abdominal compartment syndrome, thrombosis, splenic, portal veins. ICU design and details, ICU levels of care. Intensive care units. ICUs operate under a tiered classification system that reflects the complexity and intensity of care provided, ranging from Level 1, basic support, to Level 3, comprehensive, multi-organ support. Level 1 ICU basic intensive care provides oxygen therapy, non-invasive monitoring, and nursing care more intensive than a regular ward. Primarily used for patients at risk of deterioration or requiring closer observation. May provide short-term mechanical ventilation, e.g., post-op patients, or initial stabilization in emergencies, but long-term or complex ventilated cases are transferred to higher-level units. Can temporarily stabilize disturbed vital signs and initiate basic multi-system support. Often acts as a holding unit pending transfer to higher care levels. Level 2 ICU High Dependency Unit, HDU. Intermediate care provides more detailed observation and intervention than Level 1. Suitable for patients needing support for a single organ system excluding invasive ventilation, or for close monitoring post-operatively. Offers invasive monitoring and basic life support, such as inotropic support or renal replacement therapy. Typically does not provide mechanical ventilation as it lacks the infrastructure and staffing for sustained ventilator care. Patients may have chronic or transient organ dysfunction, requiring hourly monitoring and timely interventions. Level 3 ICU Advanced Comprehensive Intensive Care delivers the highest level of critical care. Provides advanced respiratory support, e.g., invasive mechanical ventilation, high-frequency oscillation and/or support for at least 2 organ systems, e.g., ventilator plus vasopressors plus dialysis. Admits patients with multi-organ failure, complex perioperative needs, or severe sepsis, ARDS, neurologic compromise. Functions as a regional or tertiary care resource, often engaged in research, teaching, and specialized therapies, e.g., ECMO, CRRT, invasive hemodynamic monitoring. Multidisciplinary team support and continuous bedside presence are essential components. ICU design, open versus closed ICU types, open ICU, multi-specialty involvement. Primary treating team is specialty-specific, e.g., surgery, medicine. ICU team assists only, not the primary team. Closed ICU, intensivist-led model, one primary intensivist manages the patient. Other specialties help only through consultation. Decision-making authority lies primarily with the intensivist. Which is better? Closed ICU is considered better, because ensures minimal conflict. Centralized authority, single person, intensivist, has the power to take decisions. HDU, high dependency unit. Purpose, provides care to patients at risk of developing acute single organ failure, excluding respiratory compromise. Functions as a step up from ward or step down from ICU. Key point, HDU equals for non-respiratory organ support. If patient develops respiratory failure, they should be transferred to ICU. Examples must know: pheochromocytoma postoperative care in HDU. Myasthenia gravis postoperative care in ICU due to risk of respiratory failure. ICU design, recovery room setup, and ICU staffing. ICU design for zones 1. Patient care zone minimum area around bed, total 20 meters to the power of 2 per bed head side. 1.2 meters each side. 1.2 meters design features, adequate lighting and ambient temperature control, AC low noise level, clock calendar and view, access to natural light, proper bed surroundings. 2. Clinical support zone central area should have central monitor, drug preparation area, computer plus internet, patient record access, reference books, policies, x-ray scan viewing. 3. Unit support zone storage space. 10 meters to the power of 2 per bed, for ventilators, water coolers, etc. Distance, storage, 30 meters from patient care zone rooms. 15 meters to the power of 2 on-call doctor room. 40 meters to the power of 2 staff lounge per 8 beds. 40 meters to the power of 2 seminar room. 4. Family support zone, TV with low volume. 10 meters to the power of 2 sitting area, tea coffee facility, separate entrance for family, nearby attendant accommodation. ICU staffing ratios must know: HDU, 1 nurse per 2 patients. ICU, 1 nurse per 1 patient. ICU doctor coverage, 1 doctor per 8 ICU beds. Recovery room, PACU, post-anesthesia care unit. Patient stay, minimum 2 hours, 120 mins. Post-op OT to recovery ratio, 1 OT. 2 recovery beds, so 8 OTs, 16 PACU beds. Additional notes: apply scoring systems like NEWS or IMUSE to assess recovery. Management of major trauma. Introduction: major trauma is a leading cause of death globally, particularly among young adults. Efficient early management saves lives. The Advanced Trauma Life Support (ATLS) protocol is widely followed, emphasizing structured, systematic care beginning at the emergency department. Trimodal death distribution. 1. First peak: instantaneous, non-survivable injuries, brain, heart, vessels. 2. Second peak, within minutes to hours, deaths due to hypoxia, hemorrhage. Timely intervention can prevent mortality. 3. Third peak, days to weeks, due to sepsis or multi-organ dysfunction. Preventable with proper initial resuscitation. Trauma team preparation, dedicated trauma bay. All equipment, airway, IVs, warming systems, tested. ATLS trained team members assigned defined roles. Rapid communication with lab, radiology, and referral centers ensured. Trauma team objectives: identify and correct life-threatening injuries. Resuscitate and stabilize. Perform full assessment. Arrange definitive care or transfer. Primary survey. C. ABCDE. C. Catastrophic hemorrhage prioritized first. Tourniquets for severe extremity bleeding. Pressure dressings for minor wounds. Initiate damage control, resuscitation, internal bleeding, urgent surgery. A. Airway plus cervical spine, secure airway. Consider intubation if GCS8, airway threat, or apnea. Maintain C-spine immobilization, mills or hard collar plus blocks. Use jaw thrust, avoid chin lift in suspected spine injury. If intubation fails, consider LMAIL macrocothyrotomy. B. Breathing, inspect chest for flail segments, tracheal deviation, wounds. Auscultate, percuss, log roll to inspect back. Administer 100% oxygen. Assist ventilation if needed. Use CXRN fast for rapid assessment. C. Circulation shock is mostly hemorrhagic. Insert 2 large bore IVs 16G or bigger. Use IO if needed. Collect blood for group, cross-match, labs. Give TXA 1 gram IV over 10 minutes, then 1 gram over 8 HRS. Cautious fluids, warmed colloids e.g., Hartmann's with hetastarch. Permissive hypotension unless TBI, MAP target 90 mmHg in head injury. Monitor urine output, lactate, basic S, and use Tegrodum if available. D. Disability rapid neuroexam, AVPU or GCS. Check pupils, glucose. GCS 8 intubation. E. Exposure undress completely, inspect head to toe. Prevent hypothermia, warm fluids, warm blankets, raise room temp, management of massive hemorrhage damage control resuscitation, DCR. Definition: damage control resuscitation, DCR, is a systematic, physiology focused approach to early trauma resuscitation aimed at preventing or reversing the lethal triad of coagulopathy, acidosis, hypothermia. Key principles: 1. Permissive hypotension, target SBP 80-90 mmHg except in TBI. 2. Hemostatic resuscitation, early use of blood products in 1:1 ratio, RBC, FFP, platelets. 3. Minimize crystalloids, to avoid dilutional coagulopathy and tissue edema. 4. Early use of tranexamic acid, TXA. 5. Prevent hypothermia. Warm fluids, patient warming measures. 6. Anticipate coagulopathy, guided by Tegrodum if available. When to start DCR? Initiate as early as possible, ideally in the pre-hospital or ED phase, when you identify hemorrhagic shock or exsanguinating bleeding, symptomatic hypotension with ongoing trauma, related bleeding, penetrating torso injuries with signs of hypoperfusion, positive FAST plus unstable vitals, clinical prediction of massive transfusion needs. Definition of massive transfusion: massive transfusion equals replacement of one blood volume within 24 hours or 10 units of PRBCs in 24 HRS or 4 units of PRBCs in 1 hour with ongoing bleeding, or 50% of blood volume replaced in 3 hours, or anticipated massive transfusion, e.g., unstable trauma with positive FAST. Aims: restore oxygen carrying capacity, prevent, treat coagulopathy, maintain tissue perfusion, prevent the lethal triad, acidosis, hypothermia, coagulopathy. Components: use a balanced 1:1 ratio, if available. 1 unit packed red blood cells PRBCs, 1 unit fresh frozen plasma, FFP, 1 pack platelets. Add cryoprecipitate or fibrinogen concentrate of fibrinogen, 1.5 gl calcium replacement. 10 milliliters of 10% calcium chloride IV every 4-6 units. Prevent citrate-induced hypocalcemia. Tranexamic acid. 1 gram IV over 10 minutes, then 1 gram over 8 hours, within 3 hours of trauma. Monitoring vital signs, ABG, lactate, base deficit thrombolistography, TEG, RODM to guide component therapy, platelets, PTINR, APTT, fibrinogen. Ionized Ca to the power of 2, Hb, termination criteria: bleeding controlled, hemodynamic stability achieved, labs normalize, complications: dilutional coagulopathy, hypothermia, use fluid warmers, hypocalcemia, from citrate, hyperkalemia, acidosis, transfusion-related lung injury. Trally, volume overload. Is DCR part of DCS? Yes, DCR is the resuscitative counterpart of damage control surgery, DCS. DCR, physiologic resuscitation principles, focuses on reversing lethal triad, DCS, surgical control of hemorrhage, contamination, and staged steps. They run in parallel. DCR optimizes the patient's physiology to survive staged surgery in DCS. Goals for resuscitation: 1. Blood pressure, systolic, 80-90 mmHg. 2. MAP, mean arterial pressure, target, 65 mmHg. 3. Heart rate, 120 bpm. 4. Urine output, UOP, 0.5 ml/kg. 5. Hemoglobin HB, 8-GDL6. SpO2, oxygen saturation, target, 92 to 98%. 7. Lactate level, 1.6 mol/L, or normalization if elevated. 8. Coagulation parameters: INR 1.8, platelets PLT, 50,000, fibrinogen, 150 mg/dl. Damage control surgery, DCS. Definition: a staged surgical approach focused on early control of bleeding and contamination in unstable trauma patients, aiming to stabilize physiology before definitive repair. Indications: profound hemorrhage, coagulopathy, acidosis, hypothermia 35 degrees Celsius, prolonged operative time or instability. 5 stages of DCS. 1. Recognition and decision made early, often in the ED. Recognize physiological exhaustion or impending collapse. 2. Initial surgery, damage control, control bleeding, packing, clamping, stop contamination, e.g., bowel resection, insert temporary vascular shunts, leave abdomen open if necessary, temporary abdominal closure. 3. Critical care, resuscitation phase, ICU management to restore normal physiology, correct coagulopathy, warm the patient, treat acidosis, optimize ventilation, perfusion, renal output. 4. Return to OR, second look surgery, typically 24 to 48 hours later, remove packs, definitive repair of injuries. 5. Definitive closure, final repair. An abdominal thoracic closure may require plastic surgery involvement for reconstruction. Benefits: life saving in exsanguinating patients, allows stabilization before prolonged surgery, reduces risk of worsening coagulopathy, hypothermia, and metabolic acidosis. Secondary survey, done after stabilization. Full head-to-toe check. Head neck, GCS, skull fracture signs, CSF leak. Get CT if suspicious. Chest, examine thoroughly. Confirm pain control to avoid hypoventilation. Abdomen, pelvis, examine, fast CT. Splint, suspected pelvic fractures early. Limbs, check neurovascular status. Watch for compartment syndrome. Spine, back, log roll with full precautions. Inspect spine, rectum. Orifices, catheter unless urethral injury suspected. OGNG tube if intubated, transfer to definitive care, decide early if center lacks resources. Coordinate with higher-level trauma centers. Secure all lines, tubes, maintain documentation. Intubated patients ideally accompanied by an anesthetist. Summary: major trauma management requires a structured team-based approach, starting with ABCDE, followed by secondary survey and damage control strategies. Early hemorrhage control, airway management, hypothermia prevention, and timely transfer to definitive care save lives. Correlationship summary for DCR, MTP and DCS, how they work together. 1. DCR is the overarching philosophy, applied immediately when trauma-related hemorrhage is suspected. Starts in ED or pre-hospital setting. It dictates early actions: permissive hypotension, early blood products, TXA, minimal crystalloids. 2. MTP is the operational tool within DCR, follows the 1-1-1 resuscitation strategy. Prevents or corrects coagulopathy and hypoxia due to blood loss. Includes calcium replacement, temperature management, and point-of-care monitoring. 3. DCS is the surgical response to trauma physiology failure. Used when physiology can't tolerate definitive surgery. Performed alongside DCR and MTP. Example: packing liver bleed, leaving abdomen open, then ICU stabilization. Key takeaway: 1. DCR equals resuscitation philosophy. 2. MTP equals blood product protocol within DCR. 3. DCS equals surgical strategy enabled by DCR. MTP. All three must run together in a time-critical, team-based approach to manage unstable trauma patients effectively. 1 and 2 started timely by time for Step 3. Acute respiratory distress syndrome, ARDS, definition: acute, diffuse. Inflammatory lung injury, pulmonary vascular permeability, lung weight, aerated lung tissue leads to hypoxemia, bilateral radiographic opacities, venous admixture, dead space, lung compliance not explained by cardiac failure or fluid overload, onset within 7 days of a known insult, e.g., pneumonia, sepsis. Berlin diagnostic criteria. Acute onset 7 days, bilateral infiltrates on chest imaging not explained by cardiac failure, fluid overload, hypoxemia, mild, POW2/FiO2 200-300 moderate, POW2/FiO2 100-200 severe, POW2/FiO2 100 all measured with PEEP 5 cm H2O. Epidemiology: lung safe, seen in 10% of ICU patients. 23% of patients on mechanical ventilation develop ARDS types. 30% mild, 47% moderate, 23% severe mortality. 34% in ICU, 40% in hospital, under-recognized in 40% of cases. Etiology: pulmonary direct, pneumonia most common, aspiration, lung contusion, inhalation injury, drowning, extrapulmonary indirect. Sepsis, pancreatitis, polytrauma, massive transfusion, drug-induced burns. Pathophysiology: exudative phase, cytokine release, IL-6, TNF, Greek letter alpha. Neutrophil infiltration, reactive oxygen species, alveolar and capillary membrane injury, protein-rich fluid leaks, non-cardiogenic pulmonary edema, surfactant inactivation, alveolar collapse. Result: shunt, compliance. Hypoxemia, proliferative phase, type 2 pneumocyte regeneration, fibroblast proliferation, matrix deposition, fibrotic or resolution phase, either fibrotic changes, stiff lung, poor prognosis or resolution with epithelialization. Core management, lung protective strategy, tidal volume. 6 ml/kg, ideal body weight, plateau pressure, 30 cm, H2O, permissive hypercapnia, acceptable if pH 7.2 peep to prevent alveolar derecruitment, individualized titrate FiO2 to avoid oxygen toxicity. Goals of therapy in ARDS 1. Oxygenation targets: PaO2, 60 mmHg, SpO2, 88 to 98% FiO2 titrated to 60%, avoid 100% FiO2 risk of resorption, atelectasis. 2. Ventilation targets: permissive hypercapnia approach, pH 7.25 to 7.42, tidal volume, VT 4-6 ml/kg, ideal body weight, PaCO 240-65 mmHg, ETCO 235-60 mmHg. Evidence-based adjuncts recommended: prone positioning, 12 to 16 hours day, reduces mortality in severe ARDS. Proceva trial, neuromuscular blockade, cisatracurium for 48 hours, improves synchrony and oxygenation, used in moderate to severe ARDS. Conservative fluid management. FACTT trial, ventilator-free and ICU-free days, no increase in ACI ECMO. For severe ARDS with refractory hypoxemia, benefits suggested in Cesar and Eolia trials. Controversial or not recommended therapies: HFOV, high frequency oscillatory ventilation, not recommended. Oscar and Oscillate trials, mortality recruitment maneuvers, mixed results, potential harm. ART trial, use cautiously and selectively. APRV, airway pressure release ventilation. Limited evidence. Small trials suggest benefit, not universally recommended. Steroids, methylprednisolone 1 mg/kg day, some benefit in moderate, severe or fibrotic ARDS. Risk: infections, ICU weakness, role still under investigation. Therapies with no proven benefit: inhaled nitric oxide, no survival benefit; renal dysfunction, inhaled prostacyclin, insufficient data; Greek letter beta-2 agonists, no benefit; statins, no benefit; ketoconazole, no benefit. ARDS management summary of recommendations: strong recommendation against HFOV, high-frequency oscillatory ventilation recruitment maneuvers; prolonged conditional recommendation in favor steroids and MBA neuromuscular blocking agents. ECMO, for refractory cases, high PEEP, individualized based on response; strong recommendation in favor lung protective ventilation, tidal volume, VT 4-8 ml/kg, PBW, plateau pressure, 30 cm, H2O, proning, sepsis 2018 update. ATOTW summary definitions: sepsis, life-threatening organ dysfunction from a dysregulated host response to infection. Defined as suspected infection plus rise in SOFA score. 2. Septic shock, sepsis with persistent hypotension requiring vasopressors to maintain MAP, 65 mmHg and lactate, 2 mol/L despite fluid resuscitation. SOFA, for screening outside ICU. Score 2 suggests higher risk, head hypotension, altered GCS, tachypnea, SBP, 100 mmHg, altered mental status, RR, 22/min, pathophysiology, initial cytokine storm, pro-inflammatory. Later immunoparalysis, dysregulated immunity, affects multiple systems, coagulation, endothelial function, mitochondrial injury, T-cell exhaustion, apoptosis led to immune suppression and secondary infections. Diagnosis: lactate. Marker of tissue hypoperfusion, guide resuscitation. Procalcitonin, helps limit antibiotic duration, not used for initiation cultures. 2 sets before antibiotics if possible. Emerging tools, molecular diagnostics. PCR, mass spec, show promise for rapid ID. 2018 surviving sepsis 1-hour bundle. Start within 1 hour of sepsis recognition. 1. Measure lactate, repeat if, 2 mol L, 2. Blood cultures before antibiotics. 3. Broad-spectrum antibiotics. 4. 30 ml kg IV crystalloids if hypotensive or lactate. 4. 5. Vasopressors if MAP, 65 mmHg, antibiotics and source control. Start early. Empiric antibiotics, delay reduces survival. Consider MRSA, Pseudomonas, fungal coverage based on risk. D. Escalate when cultures return. Remove infected lines. Devices. Surgical radiological source control within 6 hours. Fluids. First line, crystalloids, preferably balanced like Ringer's lactate. Avoid albumin unless specifically indicated. Monitor for fluid overload. Resuscitate after 24-48 HRS. Perfusion assessment. Dynamic markers preferred. Passive leg raise. Pulse pressure variation. Ultrasound. CVP and SCVO2. Now D. Emphasized lactate-guided therapy improves outcomes. Vasopressors and inotropes. First line, norepinephrine. Second line, add vasopressin or epinephrine if MAP not achieved. Dobutamine, use if low cardiac output with adequate MAP. Dopamine, avoid unless bradycardia plus low risk of tachyarrhythmias. Phenylephrine, not recommended routinely. Splanchnic vasoconstriction, angiotensin II, ADI, promising in catecholamine refractory shock. Athos 3 trial, adjunctive therapies. 1. Steroids. Hydrocortisone 200 mg day if fluids plus vasopressors insufficient improves shock reversal, not consistent mortality benefit. Trials, adrenal, ANANES trial, with fludrocortisone. 2. Vitamin C plus thiamine, some early positive signals, but no RCT support yet. 3. Blood purification, hemoperfusion e.g., polymyxin B, showed no benefit in Euphrates trial. 4. Glycemic control. Start insulin if glucose, 180 mg/dl target, 140-180 mg/dl. Avoid hypoglycemia, no benefit with tight control. Nice sugar trial. 5. Anticoagulants. APC withdrawn, no benefit. Thrombomodulin and antithrombin still under investigation. 6. IVID, not recommended routinely. Some meta-analyses show survival benefit in select cases. Key takeaway: sepsis is dynamic, requires early identification, aggressive resuscitation, and frequent reassessment. The 1-hour bundle, early antibiotics, source control, fluids, vasopressors, and tailored adjuncts are the cornerstones of modern sepsis care. Modified early warning score, MUSE, Hunt RSSC based on 8 parameters. 1. Respiratory rate. 2. Saturation rate, with therapy. 3. Heart rate. 4. Systolic blood pressure. 5. Temperature. 6. Consciousness level. A. Alert. V. Response to verbal stimulation. P. Response to pain. U. Unresponsive. 7. Urine output, 75 ml in last 4 hours equals 1.8. Nurse being worried, adds 1 point. RRT protocol. 1. If MUSE 3, contact clinician on duty. 2. Clinician assesses within 30 minutes and drafts a treatment plan. 3. Treatment effect is reviewed within 60 minutes. 4. If no effect, contact RIT. 5. If 2, 3, 4 not followed, nurse clinician contacts RIT. 6. Document abnormal parameters in patient's chart. Rapid Response Team, RRT. A Rapid Response Team, RRT, is a group of healthcare professionals including an intensivist, or physician, a respiratory therapist, and a registered nurse. This team is available 24/7 to evaluate patients who are not in ICU but begin showing signs and symptoms of clinical deterioration. The aim is to deliver critical care expertise early, in an attempt to avoid further clinical decline, cardiopulmonary arrest, or code situations. RRT is activated when a patient begins to deteriorate before experiencing cardiac or pulmonary arrest. Chain of survival in hospital: cardiac arrest IHCA. 1. Early recognition and prevention. 2. Activation of rapid response team. 3. High quality CPR. 4. Early defibrillation 5. Post-cardiac arrest care 6. Recovery. Out-of-hospital cardiac arrest OHCA 1. Assess scene safety 2. Activation of emergency response team 3. High-quality CPR 4. Early defibrillation 5. Advanced resuscitation 6. Post-cardiac arrest care 7. Recovery, chain of prevention steps. 1. Education 2. Monitoring 3. Recognition 4. Call for help 5. Response. These 5 interlinked steps form the chain of prevention. Reversible causes of cardiac arrest 4Hs and 4Ts. 4Hs, hypoxia, hypovolemia, hypokalemia, hyperkalemia, hypothermia. 4Ts, thrombosis, cardiac pulmonary. Tamponade toxins, tension, pneumothorax, good quality CPR rate. 100-120 compressions min depth, at least 2.5 inches, 1/3 RD chest compression depth, chest recoil, allow full recoil interruptions, minimal ideally 5 seconds, airway management, within 5 seconds. Changes in ACLS 2020 ACS definition. Change IV drug to be given, 10 no more recommended, 1 breath 6 seconds rather than 30, 2 early epinephrine target SPO2. 92 to 98%, rather than shock-related, 94%, device-specific shocks, rather than algorithm-based, atropine 1 mg, rather than 0.6 mg, dopamine 5-20 mcg min, rather than 2-20 mcg min. Door to balloon time 90 minutes in case of stroke. Endovascular revascularization to be done in 24 hours. Pregnant PT deliver within 5 minutes, rather than earlier 4 minutes. Respiratory cardiac arrest. Give naloxone, drugs. Atropine 1 mg, adrenaline ASAP, dopamine 5-20 mcg min, naloxone SPO2 92 to 98%, breath 1 in 6 seconds, 10/min, door to balloon 90 minutes, endovascular revask 24 HRS, pregnancy 5 minutes. Note, due to fentanyl pandemic in Europe, over the counter of